I'm Lisa Parker. I'm the Director of Emergency and Day Surgery, and welcome to the Emergency Department. The first thing I'd like to show you is our visibility wall. This is also where we have our daily huddles every morning at 8:15, and we go through our staffing and any communication that I need to get out to the ward. We look at our customer concerns, any safety alerts like medication errors, anything like that. And we also look at the number of patients that are either admitted or obs down here that don't have a bed anywhere as an inpatient yet. So we keep track of that as well. We have our standard work and our multiple skills checklists. And all of our audits from our RPIWs are here. And here we have idea summary sheets, and we have a little section for our morale, our thank yous, and that sort of thing. Good, and now I'd like to show you some of our Kanbaning and 5S'ing. If you follow me. Our very first project down here over a year and a half ago was to Kanban all of our supplies. So we have two carts. This is cart A, and it is supplied still by CSR, but we do have a two-bin system in place that works very well. And this is the frequently used cart, and we have also a cart that for infrequent use, more supplies that aren't used as frequently, but it runs on the same principle and works very well. And then we also have some Kanbaning that we did ourselves that are our store items that come from materials management that we replenish ourselves in this area. If you follow me, I can show you one of our other cabinets. We had an extensive 5S project that went on, and we Kanbaned and 5S this area. This is also another area that has supplies that are supplied to us by materials management. That's where we keep our catheter cart and our bladder scanner as well. This is an example here of our kitting. These are all of our kitting supplies for our ambulatory care areas that run out of rooms 5 and 6. So it's a central location between the two rooms, and it just helps everything be where the nurses need it when they need it. Follow me this way. I'll show you our casualty room 1 and 2. This was also another 5S project from one of our RPIWs. We 5S'd the rooms, and we got everything kitted that we need. So we have all of our emergency drugs kitted at point of use, and all of our supplies kitted at point of use. We also made some specific kits for different types of things, like we have a chest tube insertion bin, a thoracentesis bin, and a chest tube drainage bin. And everything is neat and tidy. The cords we all tucked away and made everything neat. We have the suction supplies at point of use for the nurses, and just everything where it needs to be in that critical situations that come in. And this room mirrors this room, so it's pretty well exactly the same. The only difference is that it's stocked more for a pediatric code. So we handle the pediatric codes on this side and the adult ones on this side, but they are interchangeable. All the supplies are movable. If we have two codes at the same time that are adult, we could handle them both. And we have more kitting here. We have a burn bin, a transvenous pacing bin, and a central line insertion bin here as well. We've also moved most of our supplies here to point of use. Quite often when you're working in the casualty rooms, you need things very quickly, so we have our IV, the fluid warmer, and all of our IV supplies at point of use. We've also done some Kanbaning here. This is our nursing medication administration area, mixing area. So we have some of our supplies are Kanban, and they fit into the CSR Kanbaning. They're supplied by the other bins on the first carts that I showed you. We also have some of our drugs kitted. So these are our emergency drugs. So the nurse, if she needs to give amiodarone, can just take it and go. From our RPIWs, we've had 2 RPIWs down here, and we've also developed standing lab orders for the patients that come in. So according to 30 different types of clinical presentations, we can now order the blood work, and that's done then for the patient before the doctor even sees them. We also developed an adult admission criteria tool. So the physicians are filling that out, and then the patient is getting admitted according to the criteria. We also now have up to 25 clinical pathways that we have developed for the physicians and the nurses to use for 25 different clinical presentations, which helps standardize our care in the department. We also have developed criteria for diagnostic imaging, and our nurses follow the Ottawa rules for wrists and ankles. Thank you. Hi, I'm Lisa again. We're here in day surgery now. This is our visibility ward here in day surgery, disability board here in day surgery. This is our daily management board. It shows the types of surgeries during the day, the staff that's dedicated to the surgeries, and also our PAC clinic that runs on Mondays, Thursdays, and Fridays, the staff that's dedicated to that. This little board shows the months and the statistics for those months for the day surgery, the chemo patients, and the pre-op clinics. And that's important for our patients and for our staff to be able to see exactly what's going on in here during the month. This is the main visibility board that we have. These are our target progress reports, and we've had 3 RPIWs in day surgery so far. The first one was to standardize pre and post procedure processes for endoscopy patients in day surgery. The second one dealt with our PAC unit, our pre-anesthetic clinic. And the third one was to reduce non-value added time for the COPS patients and the staff. So that is our cancer patients that are getting chemo. And that was the one we just finished last month. Our board is set up just like everybody else's board, just a little bit smaller because of lack of space, but we have our communication, our morale, cost, quality, delivery, and our safety on here. And I'll show you next our Kanbani in the back. Follow me. This came out of just our last RPIW that we did for the chemo patients. So these were a lot of our supplies that we supplied ourselves. We had to order them all ourselves. Now they are combined, and materials management is going to take over the supplying of these supplies for us. So that's going to be really a great positive change for the ward. I'll take you now to some more Kanbaning that was done in the last RPIW as well. So this area is the medication and nutrition area of the unit. So this whole area was 5S and Kanban. Everything's in its place. All our medications are now located in the same cupboard. And we have all of our supplies here at point of use for the nurses to get the IVs ready and to mix the medications. I'll take you back over here to some more changes.
So if they got it, say today is 13.
This 5S'ing came out of the first RPIW, the endoscopy RPIW, and we have kitted and Kanbaned all of our supplies so they're at point of use. And these are the stretcher bays where the patients move into when they're post-op. So everything is here for the nurses to help recover a patient, and we've replicated it into all of our stretcher bays. Another great area that just came out of the last chemotherapy RPIW is now we have a dedicated space for the chemotherapy patients to have their chemotherapy treatment with a dedicated computer for the COPS, the chemotherapy patients. And this is a quiet space where the nurse can mix medications or deliver the medications to the patient, just to provide a safe, quiet atmosphere where they're not disturbed. And it gives privacy for the patient as well. So it's been a great addition to our unit. Just go back to our visibility ward, just so there's an area here where there's no patients. We can videotape a bit more. great things have come out of all of our RPIWs. We've developed criteria for our anesthetic patients. Dr. Ishwalal has been great at helping us do that. So we'll be decreasing the number of unnecessary patients to send through PAC. They're all going to have protocols now that we follow, and we're going to greatly cut down on the number of patients that have to be PAC'd. We've developed a new patient-friendly database, so half of the database can be sent to the patient, and they can fill it out and bring it with them. So that will also decrease their time that they spend in PAC, and it makes it quicker for the nurses. Our endoscopy, we shave time off of our pre-procedure setup, and our procedure for our history and consents, obtaining that has greatly shortened as well. And great things came out of the chemotherapy RPIW as well. It was the first provincial, cross-provincial RPIW, as the COPS centers were represented by Alan Belair Clinic. And good things have come out of that, and they will be taken and standardized throughout the province. And that's all I have to report. Thank you.
Hi, I'm Yvonne Wozniak. I work in intensive care, and I was part of the Kanban 5Sing team that we did a few months ago in ICU, one of our first projects actually. We were just starting our projects here. So I'll walk you into our storage room. It was a multi-purpose storage room, pretty much everything in here that we needed on an occasional basis and on a regular basis. So what we did was we taped off the areas. We put up actual signage and pictures so that everyone is familiar with where everything should go. And so far, everything has stayed in its place. We've created a lot more working area in here to bring stuff in and out. And everything is handy when you need it. And you can see right away where it should be and where it should be moved to. And then we have respiratory storage here. This has not been 5S'd and Kanban, but it is fairly orderly, so we're happy with that. So this is kind of our multi-purpose storage room at this point. There is room for some improvement yet, which we'll slowly work on, but so far it's working good. Stepping out here, we have our vis wall. On here, we're tracking actually some ICU specific things. We're tracking ventilator-associated pneumonias and central line infections, and that's a provincial initiative that we have to follow. So we track on a monthly basis through infection control. We're also tracking, we have IV pumps that have very med-specific entries in them. We use very unusual medications in ICU. So we track on a regular basis how often we use that system in order to input the medication and have the right flow, that we're not violating the hard limits and soft limits. So that's what this tracking system is about. And it alerts pharmacy then to the fact that we're using the system appropriately, and if we have to do anything different with our medication delivery. We also track our recovery patients we do in a month, and then we have an auditing system for our types of admissions we do to ICU on a regular basis. We track sick leave, sick time, and actually sick time is on the decrease, so I guess maybe by tracking it we're keeping good care of it. And then just any time loss injuries for staff related things, which ICU has we haven't had any injuries in ICU for a very long time. So yeah, that's kind of the vis wall. That's about it. So we'll walk over here.
I know. We're just going to take it.
In ICU, we have now we have one main storage area with all of our supplies. Previous to doing the Kanban system, we had about 4 different spots that we would go to for different supplies for any one patient. So by moving our Kanban area into what was just a storage room for one supply cart, we now have 2 large supply carts and an IV cart. So if you come in the room, it looks crowded, but it's actually very well organized. We were able to put all our supplies from 4 different areas onto 2 carts. Our IV cart stayed where it was. So we organized our stuff according to the provincial system of the color coding, and went with the tube-in system for most of it. Signal cards for some things that are kind of bulky and hard to package, right? A signal card just works better for something like that was hard to put in a bin. Otherwise, tube-in system, color-coded according to systems. GI is yellow, respiratory is blue, patient care green, blood and IV and lab is all red. White is all dressing supplies. So if I'm coming to do a dressing, I automatically know, go to the white section. I don't have to search through 3 carts or 2 carts to find stuff. I go right to the white section. So it makes it very easy for staff. It was a very easy turnover. Training the staff was a very quick process because the color coding helped a lot. And as well, our supplies are grouped together, as you can see. So that made it easier. We have Kanban bin to put all the bins in that need to be supplied, and then a post for any of the cards that have to be put in just so they don't get lost. So we find it's working very well. We're still tweaking it and still being, getting the numbers down right. But we've done quite well, I think, with getting it up and running so far. You want to go over here. In this room, by doing the Kanban system in there, we also had to move some of the IV solutions up in this cupboard, and we reorganized our sterile supplies in here as well, because some of that was on our original cart and we were going to different areas for that. So we have all of our sterile supplies in one area, and this is just specialized IVs that we use just for mixing infusions and stuff like that.
Hi, my name is Angela Darton. I'm with the KPO, but before I was with the KPO, I actually worked in the OR as a CS attendant, and I was actually part of a lot of the improvement work. So the first thing that we actually did here in the OR is actually a 5S project. Now, if you saw the pictures before, you would know that this is a huge improvement. The after score for the 5S was a 3.4, and that is huge. So one of the second improvement workshops that we did was an actual Kanban event. And what we had before, we had 2 metal carts just like this one. One was here and one was flat against the wall here. And there was a lot of products on these carts. So we were able to bring the products down to only 1 cart. And I have to tell you, the system works great. It is a card system, as many other areas in the hospital are 2-bin, and Matt actually handles it. We're actually using the cards, and the staff here, they are the ones that actually handle this system, send it down, put all their supplies away. And as you can see, we have light. Huge improvement. So after we were done this first Kanban event, we actually replicated throughout the entire OR. So I can show you a few places. So this is just one of the areas that we actually did, and this is just the housekeeping, and it's a lot more organized, as you can see, and it's easier for the staff to grab all their supplies. So the replication throughout the OR actually started in January and it was completed in June. And as you can see, here's a few pictures of all the different areas that have been completed or even still being worked on. There is 25 areas in total. So another RPIW that we actually did was to eliminate waste in pre and post procedure process for case carts being picked. Now before, the CSR department was picking half the case and the OR was picking the rest of the case. And what we ended up doing is deciding that it should be one person responsible for picking the cases, so that ended up being the OR. Now pre-RPIW, it used to take 2 hours and 38 minutes for a case to be picked from beginning to end between the 2 departments. And now post, it's only 29 minutes, and that's like an 81% improvement. So another thing we did during this RPIW is we created a couple add-ons. One of the add-ons we made is the CSR would send us supplies on the lift for us, but we never knew if they would come. So they actually installed a light up there, and every time the lift is here with all of our supplies, that light goes on and prevents us from going back and forth, always checking the lift for our supplies. Now the second thing that we actually did was created a little and-on for our back door, and that was just a little green sticker that sticks to the back of the door. This notifies any of the CS attendants whether a clean CSR cart was out back, which prevented all the carts from piling up back here. As you can see, there is one here now, and the and-on is here, so a CS attendant will be coming and removing that and putting it where it needs to be.
Hi, my name is Matthew Van Noos. I'm the Director of OR and Recovery here at the MJUH Union Hospital. I'm going to introduce you to our vis wall here. It follows the same criteria that you would see at your local health district, monitoring the provincial initiatives such as wait times over three months, invasive cancer, surgical volumes, etc. I'm relatively new to this position, so when I came on, I spoke with the team about things that we would want to monitor just on a unit level here. One of the main things that came up with the team was overtime and callbacks. So we started an incident cross here to monitor that. One of the things I really like about the vis wall coming into this health district was that it provides a sense of transparency as to what I'm doing, what my goals are, working with the team, and communicating with them what we're striving towards, as well as how we're going to do it. I appreciate that it really correlates from the top of the organization all the way down to us. It breaks down what Five Hills goals are down to how we can help accomplish those goals on our unit. So it gives us a daily feedback. Here we can work on things day to day as well as month to month goals that we can see by our charts here.